With these devices, particularly with ICDs, we're going to see more of these: pocket lead infection, migration of the lead, tricuspid regurg, venous thrombosis, and ventricular perforation. I want to give you 3 cases here that I've seen over the last few years. This is an unusual cause of a stroke. There's a 65-year-old man who had a ventricular pacemaker in 1994 for sinus bradycardia. He's an active carpenter. His only medication was aspirin, and he presents 14 years later with a stroke. Confirmed by CT. He was in sinus rhythm and a normal cardiovascular exam. The investigations included routine lab work, which is normal. He's in a paced rhythm, alternating with sinus rhythm. The chest x-ray showed the lead was in the appropriate position. CT scan, however, showed multiple cerebral infarcts. Neurology asked for an echo and said, should we put him on warfarin in sinus rhythm? The echo was it was a suboptimal exam, but showed an abnormality question mark in the apex. So his transthoracic echo shows this. So aortic mitral valve looks normal left ventricular function, right ventricular function looks normal. So we did do a transesophageal echo, and you see he has an atrial septal aneurysm. And we put color on it. Really, there's not much flow across the atrial septal aneurysm. But when we took an off-axis view, one could see the pacemaker lead here traversing. If you watch the linear echo density, you'll see it crossing the atrial septum, and there's the pacemaker lead. So you have your right atrium, left atrium, and you see that linear echo density traversing the atrial septal aneurysm. When you do the T on the, looking at the apex, you can see the pacemaker lead is going across the atrial septum, across the mitral valve, and down is anchored into the free wall of the left ventricle. And when you look at the intragastric view, you can see the pacemaker lead. It'll come in and out of the view, but if you look carefully, you can see it attached to the apical portion of the left ventricle. And this is the likely cause of his stroke. He has a thrombus on the lead as it comes through, traverses the atrial septum in the left atrium. He was anticoagulated. We left the lead in because it was in there for 14 years, and he's had no recurrence. The second case is my neck is swollen. And this is where you have to talk, where you have to listen to patients and hear what they're saying. This is a 61-year-old man who had cholecystitis, and pre-op ECG showed complete heart block, of which he is entirely asymptomatic. However, the surgeon wanted a pacemaker, and he went on to have a pacemaker implanted. First the temporary, he had his gallbladder, and then he went on to have a dual chamber. But this is complicated by a pneumothorax, so that is number 1 complication of putting in a routine pacemaker for someone who had heart block, of which he was entirely asymptomatic. 6 months later, he recovers after a chest tube, but had a lot of issues. Half a year later, he's now fatigued. When you go back into his history, following his pneumothorax, he lost his voice because it damaged the recurrent laryngeal nerve, and seen by ENT, and they felt that he may never recover his voice. He did with extensive vocal training. But now he's got fatigue, shortness of breath, facial fullness. So an echo was ordered. Nothing striking. But he's tired, can't walk 2 blocks, and you see good left ventricular function. RV looks good, and there's no significant TR. So they did a CT scan. Here's a reenactment of the 3D, but he has got an extensive thrombus in his left or brachiocephalic and left subclavian vein. And it, again, just highlights multimodality imaging, how one can assess this type of patient with both 3D reenactment here, and you'll see how the thrombus is occluding where the lead's coming, and there's the big thrombus in both the left subclavian and his brachiocephalic vein, accounting for his facial fullness. So he was admitted, seen by interventional cardiology, EP, hematology, and internal medicine. And the general consensus was not thrombolysis, put him on apixaban, 5 milligrams twice a day. Seen by neurology, finds discharge because he's getting vascular headaches from his facial fullness. And ultimately, he meandered his way over to my office. Now we're 2.5 years post-implant. And his wife kept commenting, I keep telling everyone his face is swollen. A distended JVP, normal cardiovascular exam, and blood pressure. So I said, give me a picture. So this is a picture of him pre-implant. This guy was an active a man who was gainfully employed and had to stop working and retire early after his pacemaker. And you can see, if you look at this, there is facial fullness. And if you look on the right side, you can see his JVP is distended. And there's no motion. There's no A or V waves or V waves on that JVP. It was distended to the angle of his jaw. So we did another CT angiogram, because now we're suspicious that he has stenosis of his SVC as it enters into the right atrium. Again, you now see distended left venous collaterals, which is not unusual in this type of syndrome. You can see, look at the dilated left subclavian there. And again, this is the wonders you can do with CT, and you can see where it comes down to a rat tail as the two leads are coming down to the SVC. So I referred him to interventional radiology, who are very good with catheters, and this is pre-PTCA of his venous stenosis from his SVC syndrome. And you can see there where the rat tail is, where the veins are very distended until they hit the wire. And then following balloon angioplasty, not stenting, but a balloon angioplasty, he now has adequate flow going through his SVC. And the proof of the pudding really is, what did you look like after? And so 2 weeks after coming back to the office, pre-op and post. And you can see his facial distension has gone down. The reason you get headaches with this, vascular headaches, because you're obstructing your venous flow from your head into your heart, and therefore it tends to be worse when you get up in the morning, but after you've been upright for a while, you get some drainage down, and your headaches can disappear, as can the facial fullness. An SVC syndrome post-pacemaker is rare, probably occurs more non-clinically, but certainly rare clinically at 1 in 1,000, but probably does occur more frequently, we just don't recognize it. And certainly risk factors include a temporary pacemaker, multiple leads, infected leads, or a history of thrombosis. The treatment are a variety. You can thrombolyse them, anticoagulate, PTCA, or stenting. Problem with doing a PTCA is, although it's very successful, the recurrence rate in this one trial, 43% reintervention. You can put something called a wall stent in, which is very flexible for interventional radiologists use this for venous stenoses, particularly for dialysis patients. You may see this in a dialysis patient, distended neck veins. But once you put that stent in, you're committed, and you're basically mashing the pacemaker lead against the wall of the superior vena cava, and you can't remove it if anything happens. And the last case I wanted to talk about was with an increasing number of devices about tricuspid regurgitation. This is a 74-year-old man who had a porcine aortic valve replacement with bypass in 2004, had pauses, ended up with a pacemaker in 2006, and then presented to me with symptomatic right-sided heart failure. He had an echo which showed a normal aortic valve, normal prosthesis, normal LV, and his PSP, which is important here, was normal. But it did show a dilated RV with severe TR. This did not happen overnight, but you can see here he's got effectively 4+ TR. You can see the bulging of the atrial septum. He's got a small ASD or PFO. You can see the turbulent flow in the mid portion of the atrial septum. Now, what does this look like clinically? Because he was like this for a while. And I took, we did a pulse Doppler to ensure he has not got pulmonary hypertension, because it's mandatory you rule out secondary causes of his TR. And this is related to the pacemaker in this sense, and his Vmax across the TR was 2.53 meters per second. You can see it's a fairly dense jet and rapid flow or deceleration consistent with his significant TR. And this is what it looks like when you have a patient with severe TR. You can see that prominent pulsation of his vein, and this is a combination of the V wave is actually passive filling of the right ventricle, but this is an A, C, and V wave combined, and you can see that prominent pulsation going up to the angle of his jaw. Device-related severe TR is going to be more common. We have to be able to recognize it, and it's felt to be one of 4 causes: damage to the valve or perforation, interference with valve coaptation, or you can actually get a pacemaker syndrome if you have sinus rhythm, if the atrium and ventricle are paced, or the atrium contracts against a closed tricuspid valve, can result in what we call a pacemaker syndrome or pseudo-TR. It's not well recognized clinically or echocardiographically. The incidence can range from 70 to 40%. 3 to 4 plus TR can be definitely associated with reduced survival. It can be technically challenging to define the mechanism, unless you do a T. And note, if you have a PASP over 40, we've talked a lot about that, in one study resulted in up to 90% will have TR. So if you have elevated pulmonary pressures, you're going to get TR. The problem with echo or 2D, it has a low sensitivity for detecting this type of pathology. And so T is helpful, and I'd like to acknowledge Quan Chan for this. This is a paper that he wrote in 2012 in JACC, and John Vinos submitted this. He's a cardiac pathologist, showing one complication of a device lead with dense adhesions encapsulating the tricuspid valve, which is one cause. But more specifically, the more common cause is the lead interferes with tricuspid closure. And 3D is really the way to go in trying to elucidate why this patient would have the degree of TR. And of 100 consecutive severe TRs with leads put in, they found this, from Mazzetti, found most of them were related to the septal leaflet or between the posterior and septal commissure. The rest were central TR. And this again just shows you, highlights the ability of 3D to really find if you have a non-impinging or impinging lead, and at least helps one determine should one do anything further about this. So in conclusion, device lead-related complications will increase. You have to have a high index of suspicion, and echocardiography with multimodality imaging is likely a necessity. Thank you very much.